yeah?
Yeah, so we're starting in 3, 2, 1.
Good morning. Good morning. You're all very welcome to the annual members meeting for Kettering Hospital and the annual general meeting for Northampton General Hospital. This is our first combined event. We are in a group model, but we do remain separate legal entities, and we are still required to produce annual reports and accounts and do all the other things that two separate organisations are meant to do. But of course, we also do lots of things together, so we're trying to make this efficient for you listening and watching, and efficient for us because our staff are busy at the moment, very busy in fact. So users of the public link can submit questions. There is a question and answer, a Q&A facility available. You'll see it on your screen, and we will pick up those questions as part of a dedicated Q&A section at the end. We won't take them as we go through, we'll take them all at the end as we allow them to clump together into topics. A couple of housekeeping things. Please turn your camera off if you're not speaking. The meeting is being recorded and will be made available on the Trust website. Any opening remark? When I say turn your camera off when you're not speaking, what I mean by that is turn it off if you are not going to be speaking. We need to be able to see how many, the camera operators need to be able to see the people about to speak. So this is technically the report for 2021 to 2022, April. Seems like quite a long time ago, really. And it's always difficult looking back. People always sort of want to talk about now and talk about looking forward, but annual reports, annual meetings are always got a sense of looking back about them. So what did we talk about in the last few months? Well, the presenters will talk about all the things that have been great achievements. I just want to pick out a couple, really. Clearly, COVID featured a lot. I know everybody would wish we could forget about it, but from a hospital point of view, you can't. And during that period, we went back into mask wearing, we went back into COVID wards, we went back into all sorts of difficult things for our staff, for our patients, and for our visitors. And we don't underestimate how difficult it is for our visitors. So it featured a lot. Numbers are declining. I think everybody knows what the national numbers are, but I suppose just a quick plug for anybody watching: get your flu jab, get your COVID jab, please. So a second item is probably our university hospital status. People sometimes look at that and think, what does that mean? But in my view, it's the single biggest thing we could do to improve the quality of the care we provide to our patients. It offers us connections with Leicester, now the second highest rated university in the country for clinical research, particularly in cardiology, and it allows us to develop that research function in our two hospitals. And that is one of the biggest things you can do to improve the quality of your staff. And it's not just medical staff, it works for nursing staff, it works for all our allied health professionals, and we intend to broaden the link with both Northampton University and Leicester University into other faculties in the university, around analytics, around business, around IT, around a whole variety of things. And finally, it's always the one thing I tend to get stopped and asked about in my village is, when are you going to rebuild Kettering Hospital? And we have made slow and steady progress towards the new hospital for Kettering. We had the Secretary of State with us in July, who's now the Secretary of State again, and we have had the funding for the enabling works. And these things always take a long time. There's a huge amount of planning goes into it, but I think we're making steady progress towards the new hospital on the Kettering site. So that's the three things I wanted to pick out. I'm going to pass over to Andy now. Can I just do the housekeeping? If you're not going to be a speaker, can you please switch your camera off? There is one camera on that I would prefer to be switched.
Yeah, thanks, Alan, and good morning, everyone. Yeah, I'm Andy Callow. I'm the Interim Chief Executive for the University Hospitals of Northamptonshire. And as we look back on this year, as Alan said, there's some number of events that we could draw upon, and I'm just going to pick a few of those as we go through. So can I have the next slide, please? So as we've talked about, the coming together of the two hospitals into a group in July 2021, and the recognition of our university hospital status, as Alan has already said, that really brings us some great opportunities to grow our research and training opportunities, and be part of the latest treatment and research trials. And so really great opportunity for staff and also for the patient benefits. So if we can go on to the next slide, please. The other thing that we've done as a group, as we've come together, is to bring together a new shared vision and mission, recognising the shared aims we now have across the acute hospital group in Northamptonshire. And this was created through extensive conversations and workshops with staff, patients, patient representatives, governors, and health and care partners. And you'll see that runs through all of our material that we use across, and is some part of the conversation. And as you'll see, our vision is about being dedicated to excellence in patient care, staff experience, and to becoming a leader in clinical excellence, inclusivity, and collaborative healthcare. And if we go into the next slide, I'll just talk about some of the things that we've put together on the back of that. So one of the things that's come out is a vision and exercise to put a new set of values for the group. And that's really important because it sets the tone for the way that we behave and the expectations we have of each other across the group. And you'll see the 5 values that we have there that go through in all we do. And if we have the next slide, please. And finally, we have 5 priorities that we're aligned behind, supported by a number of strategies that we've agreed in the last 12 months or so. And I could talk about any of those strategies actually, but I'll just focus on the clinical ambition, because that really sort of is the place where the collaboration between NGH and KGH will really sort of take place. And through that clinical ambition that we've set out there, we'll be working with our partners to prevent ill health and reduce hospitalisation. So giving people the care in the place that they really need it and is most appropriate. We'll also be developing a Northamptonshire Cardiology Centre of Excellence, which will be led by Kettering, and a Northamptonshire Cancer Centre of Excellence led by Northampton General Hospital. And so this is about consistent access to services and bringing the specialties together to give the best service across the county. We also need to make sure we're protecting elective beds to reduce cancelled operations and reduce long waiting times. And you may be aware that across the Midlands that Kettering and Northampton are one of the highest performers, in that we have the shortest waiting list, or one of the shortest waiting lists in the area. And so the clinical ambition is part of helping us to keep chipping away at that list and continue to try and be the best for Northamptonshire. And then finally, as part of the clinical ambition, build on the university hospital status to become a hub for innovation. And as we've talked about, that gives us great opportunity through research and trials and really bringing the latest research and opportunities to patients within our region. So have the next slide, and I'll just finish by sort of picking up a few key moments of the past year. So I've already mentioned about elective surgery, being one of the best in the Midlands, which is really a cause for celebration, and it's something that we need to continue to maintain. We know that the impact on the pandemic, as Alan said, it hasn't gone away. It has an ongoing impact on all we do. It has an impact on flow and discharge. We know that there's a challenge, particularly with ambulance handovers within our area, which the flow across the hospital as a result of a number of people still in our hospitals means that we have extended length of stay. We need to keep trying to work on that with our partners. We've been part of a hospital-only discharge programme. That's been a real benefit and a cause of a source of new ideas. We've been commended on our progress around length of stay for over 65-year-olds, but certainly there's still more to do in that space. It's worth mentioning about the governance, and people often think governance is quite boring, but actually it's the important part to make sure that we're doing things safely and in the right way, and you being the best custodian of public money that we can. And so we've done a number of things of bringing different committees together with non-executive support, and that really helps in terms of comparing and contrasting and sharing learning across our 2 sites. And then the final thing to note is about the formation of the integrated care system in July 2022. And you'll see in the annual report, it talks about that being one of the pivotal moments in the way that healthcare is delivered in the last 10 years, really. And so that's come together. We've started to work more closely together as a system, a sort of change in the way that we work together, and that's a really encouraging development that we certainly a key part of. And then the final thing I'll say before I hand over to Debbie is a sort of underpinning all that work and all the things I've mentioned on it is our staff, and just a massive thanks to our staff who can, through these really challenging periods, have shown exceptional professionalism and compassion for patients. So I'll hand over to Debbie. Thank you.
Thank you, Andy. So hello, good morning. My name is Debbie Needham and I'm the Hospital Chief Exec at Kettering General. I'd like to start this morning by thanking every single member of our staff at Kettering for their unrelenting hard work over the last 12 months, and it certainly has been a challenging 12 months. So our published annual report focuses on the financial year of 2021-22. And this was the second year of the global pandemic, of which we've all been living through. And in many ways, it was more challenging for us than it was in the first year of the pandemic. And that's because we had started to see and treat patients who had had their operations and their outpatient appointments delayed during the first wave of COVID. But we've also seen a strain on our urgent care services, with many more members of the public requiring urgent and more complex treatment and care than they have before, meaning that they're spending much longer within our emergency department and our inpatient wards. An organisation, Kettering is not excluded from that, is nothing without its people. And one of my priorities continues to be the well-being of our staff. And I'm pleased to say that we had a We Care Cafe that was put in place 2 years ago at the start of the pandemic. That's now been expanded and is being run by our wonderful volunteers. And what this means is that our colleagues can enjoy their breaks in a really nice, peaceful environment with some complimentary tea and coffee. Our colleagues have also got access to many wellbeing initiatives. One of those is something that was requested by our staff, and that's the outdoor gym, which we purchased with the help of our charity. And this is a fantastic facility for our colleagues to get some exercise out in the fresh air, although I'm not quite sure they'd want to be doing that today in the rain. We would also normally have an annual awards event, which would be face-to-face, but last year we were unable to do that because of the risk of COVID spread. What we did do, we had a virtual event, which was an excellent evening and a fantastic way to thank colleagues and award them for the contribution over the past 12 months, of which there were many, many good things to talk about and celebrate. In May 2021, we introduced a virtual meeting at KGH, which was open and continues to be open to all our staff. This is called Let's Talk. Let's talk about what matters to me. It's been a really positive platform where the executive team can connect with staff to celebrate, to share successes, to make decisions together. It's been one of the many steps that we've put in place over the last 12 months in creating a culture where staff are happy to speak up, where they can share concerns and we can collectively problem solve, all of which have resulted in improvements to patient experience, quality and safety, and of course staff experience as well. Moving on to our estate, colleagues and members of the public will know that our hospital building is old, space is at a premium, and we're very much looking forward to our new hospital building, of which the enabling works, our new energy centre, has been funded. We've received confirmation of the £38 million, which is really good. This will replace our temporary boilers, our generators and the steam infrastructure, which colleagues and the public will know is 50 years old now. And I'm really pleased to say that it'll also contribute 58% improvement on our carbon footprint, which of course is the first step in our ambition to being carbon net zero. So the construction work for that will start in 2023 and will take about 1 year. We've also, in terms of our estate, we have also during the last year built a Macmillan Information Centre. This is a place where cancer patients can come for advice, meet friends, meet new friends, and enjoy a cup of coffee while sharing their own experiences. It's a lovely environment. And I'd just like to take this opportunity to thank Macmillan for supporting us with this venture. In terms of operational performance, we continue to perform well in all areas compared to our peers. With regards to 28-day faster diagnosis for patients with cancer, ambulance handover waits and 18-week waits, all those we are, as Andy mentioned earlier, in the top quartile of performers in the region. So as we move into next year, firstly, we need to improve the way we communicate to patients and their families, especially in regard to discharge. Also, our routine diagnostic delays are sometimes too long, and we will be providing additional capacity, especially for MRI scans. For our staff, we do need to do more recruitment, especially for those professions which have been difficult to recruit to previously. And we also continue to work hard to ensure staff experience is excellent. So we will be putting in place a new staff restaurant, which will be open in the new year, along with much more and many more award events, celebrations. So I think I will finish by just saying I feel that I'm in a really privileged position as a hospital chief exec, but I couldn't do my job without the dedicated staff at Kettering, especially the executive team, and I'll finish today by thanking my team for the support, leadership and tenacity over the last 12 months. Thank you, team. I'm going to now hand over to Kirsty Datson, who's going to talk to us about one of the improvements we've made over the last 12 months. Thank you, Kirsty.
Thank you, Debbie. So yes, my name is Kirsty, and thank you very much for inviting me to share our journey in implementing an amazing service. So we implemented a service called Call for Concern back in February this year, and I'm really pleased to be sharing its progress so far with you all. Just to give you a bit of background, I'm one of the senior critical care outreach practitioners at Kettering General Hospital, and I work within a team called Acute Illness Response. And our main focus is the prevention of deteriorating patients across the whole trust for adults. I'm just going to talk to you a little bit more about the service then that we have now introduced. So Richard, next slide, please. Thank you. So what is Call for Concern? It is a service that enables patients, relatives, loved ones, visitors to have a direct referral line to the critical care outreach service. And it enables them to work collaboratively with us and with the ward teams to ensure that the patients in our wards are getting the best care possible. It recognises that important role that patients and relatives that can play in spotting the really subtle signs of deterioration. And we have lots of things already in place for healthcare professionals to spot deterioration, but sometimes it's those small things that the relatives or those that know the patients the best can spot before us. And so we want to really tap into that to ensure that we are spotting these signs and acting very quickly to prevent any further deterioration. Our service applies to any adult inpatient within Kettering General, and our service is a 24-hour, 7-day-a-week service. Just to add on to, we already take referrals from healthcare professionals when they have concerns, and it just adds on to that already established service, so adding that extra level of safety. The service is already established in different trusts around the nation. So it was brought to the UK by the Royal Berkshire Hospital about 7 years ago, and has continued to have a proven track record of improving patient safety and improving the experience of our patients and their relatives. Next slide, please. So how does it work? So we have our patient, we might have our relative or a loved one that has concerns about an inpatient on a ward. They may be worried about their condition, looks like it might be worrying, and have already spoken to the ward team and not feeling that this has been quite addressed, and they still have these concerns. Sorry, Richard, if you could just do a couple of slides forward. Thank you. So what they can do with those concerns that they have already raised it at the ward level, they can take this somewhere else. So it's just giving that additional option of somewhere else to go with these concerns. We have a dedicated mobile phone that they can ring, and they will speak to a member of our team. So this mobile phone will be able to be called 24 hours, 7 days a week. And the numbers for the phone are published and promoted around the trust via posters, banners, and also on our KGH website. Next little bit for me, Richard. Thank you. And again, thank you. So when our referrer or patient, relative, whoever it might be, calls the phone, it should be picked up by one of our AIR team members. On occasion, obviously, our priority is with our patients. We might be already with a patient, so if we don't pick up the phone straight away, there is a voicemail service, which we will call those people back straight away. But it will be answered by an AIR team member as soon as possible. And that just provides that opportunity for the referrer to express any concerns that they have about their loved one's clinical condition. Next little bit for me, Richard. Thank you. At this point, it might be that the AIR team ask a few additional questions. So it might be, where is your relative? What's their name? What's happened so far? Can you tell me where they are in their care journey, for example? And that just helps us prioritise our workload, but also make sure that we are giving the right advice and doing the right thing for that person in that specific case. Next bit, Richard. Thank you. And again, just keep going. Just keep going. Thank you. That's lovely. So it might be two options that we go through. So one might be that we listen to the concerns, and actually it's not best placed with us. So we might find that the concerns can be dealt better by another service. So we have a great patient and patient relative liaison service that deal with lots of different concerns, complaints, compliments, and it might be best placed with them if it's outside of a clinical concern. So we could give that information. Particularly our maternity service already have a very similar safety netting service in place, so we could signpost there. Alternatively, it might be that the most appropriate course of action is for one of our members of the team to come and see your relative or come and see the patient, and that would warrant a ward visit and a review. And that's where we would come and take a look at the patient and the journey so far, liaise with the ward teams and ensure that that patient knows why we're there and what our aim is. And so that's to look at what's happening so far. Is there anything else that can be done? Or is it just a matter of reassurance and working alongside the ward team to ensure that that has been communicated effectively to everybody involved in that care? And next slide, please. If that is the case, obviously consent always comes into it. We'll ensure that we always gain consent from the patient themselves, but we would then feed that back to that referrer and ensure that any questions that they had, any concerns have been answered, and worked together to ensure that everybody's experience is there, and also that the patient is safe and they're getting the best care possible. Next slide. Thank you. And again. Thank you. So like I said, we've been established since February 2022. And so far we've had overwhelming positive use of the service, which is fantastic. So compared with the Royal Berkshire, we've actually seen 2 to 3 times more referrals than we actually expected. And hopefully that's because we've really pushed this as a priority on the agenda for our trust. Majority of the referrals have been entirely appropriate, and they do relate to concerns around that patient's clinical condition. And a lot of the time, as we know, it's that those communication breakdowns that we've been able to get involved with. So overall, the outcomes for our patients have been really positive. We haven't had any of our referrals needed to be admitted to higher levels of care, so intensive care. we have had several cases where actually our team has come along and helped instigate new interventions or further interventions, which have resulted in the improvement of that patient's clinical condition. Majority of these reviews have highlighted that the level of care has already been very adequate for that patient, and actually what we were able to do is provide reassurance for our referrers, so our patients, our relatives and loved ones. So that is another positive that's come out of that, is giving that reassurance that wasn't already there. Part of our data collection, yes, we count the numbers, but what is really important is that impact that we have on patients and relatives' experience. So we were collecting feedback from our service users, and as you can see there on the slide, there's some quotes taken straight from our feedback, which are amazing. But overall, we've had 100% of our feedback have found that the service is easy to access, 100% saying it's extremely likely to recommend the service to others, and 100% extremely satisfied with the outcome of the call, which is amazing. Next slide, please. So that is our new service in a bit of a nutshell. Any further information on the service can be found by this QR code, which takes you to the KGH webpage. Our referrals line is as below, and we are available for any questions via our email as well. Thank you very much for listening.
Heidi, I think we're standing straight over to you.
Okay, thank you. So I'm Heidi Smolt. I'm the Hospital Chief Exec at Northampton General. So I'm Debbie's equivalent at Northampton, and I joined during the year that we're referring to in this annual general meeting. So I'm really privileged to join partway through the year when some of the initiatives I talk about had already happened, and some of them I was really privileged to be part of. So I'm going to pull a few out to share with you today, and then a couple of my colleagues will be coming along to talk to you about two initiatives. So as Debbie, these jobs are hugely privileged, and the team at NGH are a team that have overwhelmed me, welcomed me with their dedication, their teamwork, and their commitment to patients, particularly coming, as I joined, as they were coming out of a really difficult time of the pandemic. Prior to me joining, one of the things I'd like to highlight is that on the point of wellbeing is the NGH was recognised for being Health and Wellbeing Employer of the Year in 2021. And this is an absolute testament to the dedication here of the importance of wellbeing for our teams and our individuals and collective teams together. And part of that is what we call our SOS team, who really give dedicated and just inspirational support to our teams when something may have happened, so they could give support when something has happened on a ward and they might need debriefing, or they might need immediate support, or if as an individual I feel I need support, I can access them myself for just, it doesn't need to be at the extreme of I'm feeling really stressed. It could be early on, and it's genuinely about well-being and making sure that we look after ourselves as individuals, because we know from research and from our own experiences that if we have staff that are happier, feel more fulfilled, are thriving, then they will deliver better patient care. So this dedication and really responsive service from our SOS team is something that we're really, really lucky to have, and has shown some really incredible impact in a positive way for our teams, and it continues to grow and strengthen. So that's one thing I'd like to highlight. Another thing around our wellbeing is our new refurbished restaurant. We're hearing really positive feedback, both from patients, visitors, but particularly our staff, around how this gives them a space to really look after themselves and take themselves away from the clinical areas. We will have a space coming up called Our Space in the future, which will add to this wellbeing space, but hopefully you can see the importance of wellbeing from our people directorate, but equally from our estates team and all of us, in terms of the importance of how we make our teams feel when they come to work. and how we support them, particularly coming out of the pandemic. So similar to Debbie, we have an initiative similar to Let's Talk. NGH, it's called Connect, Explore, Improve. I implemented that when I joined with my team. And this is really, again, underpinned by the research and the evidence that suggests when you have teams that are truly empowered and feel valued, feel they have a voice, they will not only thrive as individuals and become the best they can be at their expert area, we will have stronger teams and we will deliver better patient care and better patient experience. So it's been one of my priorities since I started. So we do Connect, Explore, Improve sessions on an individual basis, team basis, but we have a weekly session with the executive team where anyone can join, and there's really meaningful multidisciplinary team conversations around some of the challenges teams might be facing, a safety issue, or an idea that somebody has that they want to share or need support with. So it's a real priority for both organisations, but at NGH through Connect, Explore, Improve to make sure we're focusing on what really underpins a high-performing organisation. And we know that that is underpinned by having teams that are really happy, really thriving, as I say. So that's an initiative that will keep strengthening in terms of us making sure we recognise that culture is an important area that we need to improve at NGH, which is shown to our staff survey results. But teams are feeding back really positively on that, and we've seen some initiatives that are really strengthened through that. So that's a real positive, and it's really important because we're obviously a huge employer for our community, and therefore by making our teams happy, we're having a positive impact on the health and well-being of our community too. And a few other areas I'd really like to pull out from an estates perspective. We had a new paediatric ED that opened in July 2021. And then Princess Royal visited in September. So we were really honoured to have that visit. But obviously the difference the paediatric EDs made to children and their families having a dedicated area, we know that it makes an ED safer to have a paediatric dedicated area, but also their experience will be enhanced. So that's been hugely successful and a really important part of our safety journey. We've also had a new entrance, which has a new retail, Costa Coffee and Marks and Spencer, etc. at the beginning, which might sound quite, simple in terms of, but again, that extra space for people to connect with each other, for relatives to have an environment that they can go to different places and have a choice. But that's also coupled with the refurbishment of our restaurant that I referred to earlier. In July this year, so it's slightly out, but I will refer to it, is of the time we're referring to, is we opened our new ITU. So it's really important to recognise that. And we've also secured just under 21 million to improve our carbon footprint. So that will be something that we'll update on next year as well, but we've secured that funding and that will work towards our carbon friendly ambition as an organisation and as a group. Similar to Debbie, our performance, we are hugely challenged in terms of our urgent emergency care pathway, in terms of demand coming through our ED. And we do, because our ED is known to be small, we do have challenges around ambulance handovers, but we are hugely recognised, both hospitals actually, to be in the upper quartile for our elective and cancer performance. So we're really focusing on making sure that we are treating our patients as quickly as we can for our community and the patients and public that we serve. But at the same time, we've been recognised by our same-day emergency care regionally and nationally as being a really high-performing team that are looking at different pathways to make sure people are seen in the most timely and safe way as possible when they come on our urgent care pathway. So there are a few things that I wanted to highlight. Like Debbie, I can't thank the teams enough. I've been hugely welcomed by Debbie too, but by my executive team. And it's really important that we collectively, moving forward, continue to draw on and enhance the clinical collaboration across our group, because there's been some really positive pieces of work across the group. So for us at NGH, as Andy said, one future focus will be the Cancer Centre of Excellence, and we'll also be really focusing on continuing that focus on patient experience and well-being for our teams going forwards. So I'm going to hand over to Dr. Jonathan Hardwick, who's going to give you an update on some work we've done, which has really improved the safety of our patients. And also then he will hand over to Dr. Hemant Namadi, who will update you on our surgical robot.
Sorry, Heidi, I think we'd do the Hemant's bit first in terms of the slide. Or are you happy with that?
Yeah, that's fine.
Okay. So Hemant, I think, is coming in now. Yeah, thank you.
Thank you, Heidi. I'm Hemant Namadi. I'm the interim medical director and a consultant urologist. With great delight, at the beginning of this year, we received news that we have received funding for implementation of robotic-assisted surgical services, which is a minimally new invasive technique for all the patients of Northamptonshire. Next slide, please, Richard. So what was happening is the patients across our county had to travel to Leicester and even to London to access these services. And across other specialties like colorectal and gynecology, they had to choose alternative, either open or laparoscopic. So so robotic assisted services has helped us to implement these services closer to the home for the patients, have reduced the waiting times, and has got collateral benefits to the recruitment and retention. So the robot was installed in March this year, and since then we have completed training across 3 specialties, and 4th specialty is currently being trained across both the hospitals, and 80+ patients have undergone this surgery successfully. Next slide, please. So what it means to our patients is definitely improved patient experience with shorter stay, better outcomes, reduced mortality, reduced morbidity, faster recovery, which definitely helps. Secondly, the most important is timely treatment closer to home, which is not disjointed across several hospitals. From the staff perspective, definitely the minimally invasive robot helps with reducing risk of injury, but there are wider benefits in terms of attracting talent to the county, in terms of recruitment, retention, training opportunities for junior doctors, and linking with various universities as a university hospital status permits us for starting some robotic fellowship posts within the county. And as a group, as Heidi has alluded, our ambition is to develop ourselves as a cancer center of excellence, and this is a huge step towards that. It gives opportunity and access to the patients within the county for various research opportunities, which this brings. And it is a fantastic service which we have embedded within the county, and we are quite ambitious in terms of expanding this in terms of different platforms, numbers, and getting more doctors trained on this. Thank you. I'm going to hand over to Dr. Jonathan Hardwick now.
Do you want me to put my camera on, guys?
Yes, please.
Okay. There we go. Thank you for handing over, and thanks for the time, guys, to present this. What I'm presenting is the deteriorating patient digital task list that we've done in Northampton General Hospital in conjunction with the patient safety team, the outreach team, and all the wards. Basically, this has been a whole hospital rollout and a real improvement benefit across the trust. Charlotte Hoodless isn't available today as she's lost her voice due to a cough and a cold. Next slide, please. Essentially, this is a quote that I never want to see again in a SI incident investigation report. Mrs. A's news, which is the early warning score, was consistently elevated, and despite that raised news score, Mrs. A's condition was not escalated. So whilst we have flags available in our system which can raise a flag around an early warning score for somebody's condition which may deteriorate, the question for me is, what do we do next? And our ambition is to create zero harm care. So we are trying to produce a proactive, not reactive, patient safety task list, which is centered around a raised early warning score, which comes through a digital system and then creates digital forcing functions and safety nets so that these patients don't fall through any gaps in our system, as we know is a very pressurized system right now. Next slide, please. So in summary, what we did is we had real-time data from incidents which happened within the trust. We've generated a task list which gives us live data out of the back of this, and that is key for improvement cycles. This is not reliant on human beings. This is not reliant on a manual audit. And the data that comes out of our information system, it allows us to go forward to each ward and clinical area on a monthly basis and create a conversation where the ward areas understand the trends in how they react to early warning scores before the incident occurs. Therefore, it's a proactive intervention. It's an opportunity for the staff to learn what goes well, proactively respond to adverse trends, and share what they do with their neighbouring wards. What we built is essentially a forcing function where everybody who has a high early warning score is automatically alerted to the clinical outreach team. There's no phone call, human factor, human error involved in this. It's an automatic function. At the same time, there is a set of tasks which are really quite straightforward tasks. Nothing is rocket science with this, but it creates an aid memoir as a safety checklist. Safety checklist science exists in aeroplanes, Formula One, theatres. This is just bringing this to the wards. And what this has done is it's allowed us to prevent avoidable deterioration using this automatic safety checklist. The key outcomes, I did have some graphs, but I thought it was better to talk through this, that since launch in March 2021, we've had no serious incidents, no comprehensive investigations which relate to deterioration or failure to escalate. We've reduced our unexpected critical care admissions from the base wards. So that is excluding the A&E acutely sick patients. These are patients on the ward, and we've compared this data to pre-COVID, intra-COVID, and now this year's data, and we're seeing a marked stepwise improvement. We've also reduced preventable cardiac arrests over that same time period, and we may well have contributed to our improvement in hospital mortality, but I will hands up say that the improvement in hospital mortality is multifactorial. We've increased the numbers of junior doctors, we've changed the way that we've done our rotas at the weekends, etc. So for me, this is a huge improvement. We've got a sustained improvement. We've got measurable outcomes as in preventable cardiac arrests and ITU admissions. The wards absolutely love this because they get to know their data. They get to know the patient safety team. It builds a relationship. And actually, when we're walking out and about on the wards with our patient safety team, we get to know about some other things that might be going on that's not related to this. So it's got multifaceted benefits, really. Next slide, please. This is just a gratuitous advert because we got recognised nationally at the HSJ Awards last week for highly commended in our early stage patient safety innovation of the year. So well done for everybody at Northampton General. This is an idea, but the work has been done by the nurses on the ward, the outreach team, and the patient safety team. That's the end of my talk. I don't know who I'm handing over to.
I think it's over to me. Thanks, Dr. Hardwick. So hi, I'm John Evans. I am the Group Chief Finance Officer, so the accountable officer for finance across both Kettering and Northampton General Hospitals. I'm going to give you a brief run through of our financial performance for the year end 21-22, and then explain what that means in terms of our efficiency and our audits, and then a bit of a forward look in terms of this financial year. Over to the next slide, please. So in terms of our performance across the 21-22 financial year, Kettering General Hospital ended the year with a deficit of circa £400,000, and Northampton General Hospital ended the year with a surplus of circa £400,000. I'll give a bit of a context in terms of the financial arrangements that were in place last year. They were a bit of a change from the previous year. So there was continued financial support for ongoing impact of COVID that was significantly disruptive last financial year, but also, as I believe Debbie's already described, last year an absolute focus on kind of service recovery, and in particular resumption of planned care, so elective surgery and outpatients. So the financial arrangements that were put in place were there to help drive those types of issues and those types of challenges. Funding was provided on a fixed allocation basis, and in actual language that means we received a block amount of funding. The previous financial year we had all of our costs covered, i.e. we were funded on the basis of costs incurred. Last year we moved back to a position more similar to what happened before the pandemic. We were given a block allocation of funding and asked to work within it. What it wasn't, though, is a move back to complete pre-pandemic levels where we are funded or paid for on the volume on the basis of activity. So funding wasn't on an activity basis, but it was fixed, and we were expected to live within our means, both across our two key hospitals and within our system, so the Northamptonshire ICS. Our performance, so if you add one and the other together, we get to break even. The expectation on the system, so Northamptonshire ICS or integrated care system, was to deliver break even, and we contributed to our system being able to deliver on that expectation from NHS England and improvement as was. Next slide, please. So we have audits completed at the end of each financial year. We have individual audits carried out at both Kettering and Northampton, given that we are standalone organisations. From an external audit point of view, both sets of accounts were approved by audit committees on behalf of the Trust Board within reasonable time, and our external auditors provided, or we received, an unqualified opinion, that's the good one, on our accounts. So positive there, and no issues to flag. Next slide, please. What our auditors now do, and colleagues that are kind of used to the focus of audit, both not in terms of just the review of the accounts and whether or not they are factually and materially correct, that was the previous slide. They also have an expanded role and remit to assess the value for money, or VFM, assessment of our organisations. They do so across three key domains: financial sustainability, governance, and improving economy, efficiency and effectiveness. And I'll just briefly run through what that assessment has concluded with, both for Kettering and Northampton. So in the bottom right hand corner of this slide, you can see some little traffic lights. For Kettering, so across those three domains or those criteria, there have been no significant weaknesses flagged. That is a good position to be in. There were significant weaknesses flagged in our auditor's judgment for financial sustainability in the previous financial year, 2021, but we have now improved, and you can see the little colour moving from red to orange for the judgment on financial sustainability. That's a good news story. We have a not so good news story around the assessment of improving economy, efficiency and effectiveness, which has moved from green to amber. The main reason for that is not around our ability to deliver the 3 E's, but more around our adherence to what was considered to be best practice around procurement procedures. It's not a concern. If there were concerns, a significant weakness would have been flagged. It wasn't, but our auditors took a view that at Kettering in particular, we had not demonstrated enough basically adherence to best practice around procurement procedures. We have, since this review and those recommendations being carried out, made a quite significant set of changes, both in terms of the oversight and detailed procedural changes in response, and I'm comfortable that we are on top of that item and indeed are managing that risk. Next slide, please. So on to Northampton's auditor's annual report and that value for money assessment and recommendations. So you'll see again a position where our external auditors, Grant Thornton, have not identified any significant weaknesses. So there are no reds in the column for 21-22. That is an improvement on 2020-21. So much like Kettering, there has been an improved assessment of financial sustainability. We've moved from red to amber, no significant weaknesses identified. And from the improving economy efficiency and effectiveness, that has been maintained at green, aligned to my comment around Kettering and specific procurement best practice there. So what we are looking to do as part of our working across the University Hospitals of Northamptonshire and our group model, we have put in place a set of group arrangements for procurement. That has quite quickly allowed us to learn from and implement best practice that has been happening at Northampton routinely, and has meant that we're able to start going into those wider conversations around procurement at scale and delivering kind of value for our patients and for the taxpayer across that area. Next slide, please. So a bit of benchmarking here. I presented this last year and thought it'd be appropriate to do the same. So we complete what's called a national cost collection exercise, and that creates a score for us, what's called the National Cost Collection Index, or NCCI. In the year that was assessed, that was the 2020-21 year. So just to reference, that's a year behind when the accounts were carried out. It takes about 6 months for national colleagues to crunch the numbers on this type of thing, collate all of our data and show where we sit. That year, the 2021 year, was significantly impacted by the pandemic, both in terms of the costs incurred. We increased quite a significant amount of costs in order to maintain safety and service delivery during that period, but also in terms of the clinical activity that we had delivered. We stepped down a significant amount of planned care activity, which has had, again, a significant impact on our cost base. That has been the case nationally, but clearly impacted by local decisions, etc. In terms of where we land in those scores, Kettering has landed at 101 versus the average benchmark of 100, and Northampton's landed at 99 against that average score of 100. So both are materially in line with that national average. If you're a couple of points either side, you're pretty much in the average, which says that we, during that period of time, were had broadly incurred the same level of cost for the volume of activity that we carried out compared to others nationally. We have access to and receive and review routinely where we are against this benchmarking type data. We continue to use it to target opportunities to improve productivity and value. And as and when this data becomes more and more meaningful, the next round of data for 21-22 will certainly fit that requirement. We'll continue to develop and run initiatives and change programs on the back of what that data is telling us. Next slide, please. So capital spend, it's been another significant or bumpy year for capital investment across both Kettering and Northampton in 21-22. There has been significant investment being made possible through our successfully writing business cases and bidding for extra monies. I'll go through that in a second. In terms of the headline numbers, total spend for capital at Kettering was 18.4 million. At Northampton, it was 27.4 million. The major reason for that difference between the two, some 10 million, is around spend on our new critical care facility at Northampton, which has already been referred to by colleagues, and also the fact that a larger chunk of investment in digital has happened at Northampton, partly because of the lower level of historic investment on that site, and partly given where those programs were delivered from during the 21-22 financial year. As has been referred to, but just so I can align with the money, we spent the best part of £2 million on a new surgical robot at Northampton. That was from successful bidding of new money. We were also able to invest an additional £5 million across Kettering and Northampton to implement new digital investments to do things like providing new tools to manage, schedule and deliver improved patient care, but also help provide us with better data to be able to make more timely and accurate decision making. So some of those programs have already gone live. Some of them will continue to go live as we work through the 22-23 financial year. We were one of the largest recipients of any system in the country for digital investment in the 21-22 financial year, and I think that says a lot about our digital aspiration, but also our willingness to kind of take on those big challenges and make investment at scale and pace. As has already been referred to, but given that it's a large amount of money, we completed the majority of spend for our new critical care facility, as I've said, at Northampton. That closed off, and there'll be a smaller set of numbers in this year's books. And we continued at the Kettering Hospital to continue to invest in the development of our site, and the line to look for that is the line that says HIP2 New Hospital Development Programme. So that's investment in understanding what needs to go on the site. It's investment in developing a business case to go through the relevant approval cycle. And Debbie's already referred to the funds that have already been agreed for us, and again will start to impact from the 22-23 financial year moving onwards. And then over to the final slide for me, if you wouldn't mind. Thank you. So what does this mean in terms of this new financial year, 22-23? So as I alluded to in the kind of financial arrangements for 21-22, there has been a substantial change back to the types of financial arrangements that were in place before the pandemic. The system, that's Northamptonshire ICS, have received a funding allocation. We have received a portion of that funding allocation, predominantly on a block basis, but driven by the activity volumes that we were planning to deliver in 22-23. The money this year is considerably more difficult than it was last year and during the pandemic. There has been a removal of the majority of financial support, both in terms of those costs added during the pandemic for COVID, and also in terms of kind of transitioning support for other areas. There's been a notable tightening of financial controls, and as a result of that, we are required as our two hospitals and as a wider system to refocus on the delivery of greater levels of financial efficiency. On the back of that, there is a clear and definite refocus on the efficient and productive use of resources, and the challenges of doing so when we're in a situation with multiple competing fronts around the pandemic escalating and kind of ebbing and flowing, a significant and relentless focus on recovery of planned care, of which Heidi certainly referred to us being in the upper quartile for all domains in the region, and that's as a result of us being able to resume those types of activities and capacity. This year, the ask on us, we have a system plan, an ICS-wide financial plan, as we did last year. The requirement is for us to deliver a break-even position. We have agreed as part of that for Kettering to post a planned deficit of 5.1 million, and for Northampton to post a planned deficit of 1.9 million. Probably the important context for me to raise in that conversation is we were asked to plan as part of national planning guidance to assume that COVID and wider operational pressures will be minimal. We have had an extremely challenging summer, both in terms of flow and in terms of the costs of providing and ensuring safety within our two hospitals. We were asked to plan for significantly lower levels of cost inflation than have been realised and we have seen. And as a result of those two specific items, as well as the ability to deliver that significant clinical change and step down of costs from those added during the pandemic, we're currently working through what the impact of those changes versus assumptions means for us, and those kind of decisions to manage that risk and delivery. So that's pretty much it for me. I'm going to hand over to Fiona and Deborah for an update on our quality reports.
Thank you, John. Good morning, ladies and gentlemen. My name's Fiona Barnes. My colleague Debbie will be introducing herself as part of this presentation a little bit later. But the presentation that Debbie and I are going to be sharing with you is looking at the Kettering General Hospital Quality Report and the Northampton General Hospital Quality Account. Next slide, please, Richard. So what are the Quality Report and the Quality Account? Here at Kettering, as a foundation trust, we produce a quality report. Northampton General is required under the Health and Social Care Act to produce a quality account. Both these documents are mandated documents. And what these documents and reports do is to help us as an organisation, individually and collectively, to improve the public accountability for quality of care that we provide. Each of the reports are seen nationally. The quality report is seen through the parliamentary team, and the quality account goes to the Secretary of State. Next slide, please. Here at Kettering, we have set ourselves a number of priorities. 3 priorities for patient safety, 3 priorities for patient experience, and 3 priorities for clinical effectiveness. Our first 3 priorities, patient safety, I'm just going to talk through. So on the slide in front of you, you will see a title heading for each of the priorities that we have set and how well we achieved each of those priorities. The first priority was associated with reducing the number of falls that our patients were experiencing while in hospital. And over the last 18 months, we've implemented an extensive improvement programme that's looked at how we assess our patients to see how risky it is for them, not only to be in hospital, but in particular in regards to a fall. And what we've been able to do through that assessment is improve our documentation, improve our training and development, and ensure that we have clear observations of those patients that need additional support. And we have managed to achieve our priority. Our second priority focused predominantly within our maternity unit and looking at how we can learn from incidences. Many of you will be aware of the Ockerton report. Donna Ockerton reviewed an organisation, a trust, Telford and Shrewsbury, and wanted to identify and made significant recommendations in regards to how the maternity services should run. So for us, through those recommendations, we've been looking at how we can learn from any of our incidences. And we've been able to do this through a multi-professional perinatal team, which is monitored on a monthly basis. Our last priority within patient safety is keeping our hospital clean. And you will recognise and appreciate that as we have had the global pandemic, and as previous speakers have spoken about, the hospital continues to experience waves of COVID, where we need to protect not only our patients, but our staff. So ensuring that we have a clean hospital is critical. And we set ourselves a target of ensuring that our infection prevention audits would be above 90%. And I'm pleased to say that we've managed to achieve 95%. Next slide, please, Richard. We've got 3 priorities within patient experience, and unfortunately, this is an area that we need to focus upon. The first one associated with supporting our patients leaving hospital. We wanted to reduce the number of patients who were in hospital longer than they needed to after being confirmed that they were medically fit to leave hospital. We haven't been able to achieve those numbers, but what we have done is, as Andy mentioned at the beginning of our presentation, work very closely with the National Hospital Discharge Programme, and we've seen some positive improvements, particularly looking at the Home First strategy, which ensures that we can assess our patients both in hospital but also at home for their ongoing care packages. The second patient experience priority was about how we communicate with our staff, how we communicate with our patients by our staff. And what we wanted to do was reduce the number of concerns and complaints that we had raised about our staff and the inappropriate discussions that may occur with patients. Again, we have made some improvements year on year, but we haven't sustained that improvement, and that's the area of focus that will move forward into this year. Our next patient experience priority is looking at how we can engage the public, our patients and carers and their relatives and families with everything that we do here at the hospital. And we've had some really positive events looking at how we support our learning disability and autism clients and patients, but also within our paediatric services. Next slide, please, Richard. Clinical effectiveness also has 3 priorities. The first one is about how we support our patients make decisions when they are unable to do so themselves. And this incorporates the Mental Capacity Act, in particular focusing on those patients where we need to consider a do not resuscitate or do not attempt cardiopulmonary resuscitation. We wanted to improve on our previous years and have a trajectory of 85%. We didn't achieve 85%, but we have improved our trajectory, which is good. But we will continue with this target next year. Our second clinical effectiveness priority was about supporting our frail and elderly patients that attend our hospital and may well be admitted. And we have done that through our emergency department, being able to recognise through our clinical assessment those patients that require additional support from our frail and elderly team, which has been very positively received. Our last clinical effectiveness priority this year has been ensuring that any procedure that is undertaken with our patients through the year, we can maintain individual safety. And we've done this by using the national safety standards for invasive procedures, which again, we have achieved. So moving on to the next slide, please, Richard. So what are our next set of priorities? Again, we will be looking at patient safety, patient experience, and patient effectiveness. Next slide, please. So for each of these priorities, what we've done is looked at those areas of concern or instances or data exits that we have had through the organisation and undertaken horizon scanning to see what topics are of priority across the national healthcare system. So for patient safety, we are looking at avoidable harms. Thank you, Richard. And our first priority is ensuring that as an organisation, we are aligning ourselves with the national patient strategy. And that means looking at our internal processes, our policies and procedures, and ensuring that we engage with our lay volunteers, which means that we can have the voice of the patient around our table. The second patient safety priority is about eliminating wrong site surgery. And this is about learning from external and internal processes and procedures that may occur in regards to our surgical directorate to ensure that we undertake what we call root cause analysis to ensure that any learning is shared across the organisation and organisations as we work with the Northampton General Hospital. Our last patient safety priority will be and is ensuring that there's a culture of safe space for our staff, so we know that they feel able to raise any concerns or issues that they may have within the clinical setting. Next slide, please. From a patient experience perspective, we also have 3 priorities. Next slide, please, Richard. Thank you. Our first one is going to be focusing on a learning disability and autism. And we have a strategy that promotes the care of this group of patients. And we will be focusing on how we ensure inclusion and engagement with our patients and their carers and families, but also look at recognising and protecting the individual rights. We will continue, as mentioned earlier, to focus on the communication that we have with our patients and their families to ensure that we reduce the negative comments that we have received. But we also, as our last patient experience priority, want to ensure that we continue to engage with the public, with our families, with our carers, and importantly, our patients about the changes that we may be making here at KGH. Next slide, please, Richard. So clinical effectiveness is how we improve the services. And again, we've been able to look across our services to identify those areas that we need to improve upon. Next slide, please. So clinical effectiveness, we will be focusing again on Mental Capacity Act and ensuring that our patients are supported to make the right decisions in relation to their care. We will also be looking at all cases of those patients who have unfortunately died with us at the organisation to see if there's any learning that can take place across our organisation and across to NGH in regards to the patient experience and patient death. And lastly, on this slide, clinical effectiveness, we will be ensuring that all our internal processes and policies align with NICE guidance, and NICE stands for National Institute of Health Care Settings, and to see if there's any gaps within our services that we need to address. So they are the priorities from Kettering General Hospital. I'm now going to hand over to Debbie. Thank you.
Thank you very much. Thank you, Fiona. And my name is Debbie Shanahan. I'm the Interim Director of Nursing Midwifery at an AHP at Northampton General, in a very privileged position. The NGH Quality Account included a 3-year plan from 2019 to 22 with 5 key factors. However, it is noted that some of these plans were affected due to COVID, and that has been mentioned earlier in other presentations. Next slide, please. NGH's key factors for improvement was the safety culture, preventable harm, effective and efficient outcomes, patient experience, and outcomes in maternal neonatal care. So how did we do? Next slide, please. With the safety culture, we picked out what were 4 elements. The 4 elements were firstly to aim to increase the reporting incidents with the aim to understand why things go wrong and how to prevent the mitigation reoccurrence. And I can say that we have achieved this. Safety huddles was one of our other safety culture that happens at Northampton. This has continued to happen. They are twice daily safety huddles where senior nursing staff come together to discuss safety and staffing concerns. It's led by the matrons with the Associate Directors of Nursing in. Sorry, I was just distracted by something that came up in the corner. Apologies. So this was particularly useful within the pandemic. Our nursing vacancies. Our registered nursing supply and demand remains one of the most challenging workforce issues and risks at local and national level, and with significant number of RN vacancies across the NHS. We have around last year, the year that we are talking about, it was around a 7% vacancy rate, which had come down from 13% here at Northampton. And again, we have achieved this. We have successfully met our 21 international educated nurse commitment, with 105 internationally educated nurses recruited and arrived at Northampton General and have been onboarded successfully. We also do twice yearly an annual staffing establishment review and is in place to support the alignment of the staffing reviews. But we know we still have work to do because the national picture is not getting any better. And the staff survey, the last thing from the staffing culture was the staff survey, was the staff safety culture is now aligned to we are safe and healthy people element, and it has been aligned to that. We have, next slide please. Next one was preventable harms, and within Dr. John Hardwick's tool he has talked about deteriorating patients, and there's been significant work produced about the VTE risk assessments and the root cause analysis behind. The aim of this is to The quality account, the current compliance of the root cause analysis is 91%, and this figure has increased since, so we've achieved that. Pressure ulcers were almost there, with exceptions from and during the first and second waves of COVID. It's been very, very difficult too, but we continue to do focused and increased work around and targeted work around our tissue viability work and pressure ulcers. Falls again throughout 21 and 22, 100 per 100,000 bed days, we remain below the target, the trust target of 5.5. However, we do know that we still have work to do, and we have been with our colleagues in KGH looking at some of the work that they have been doing and learning from them. Next slide, please. Efficient and effective outcomes. As you know, the hospital standard mortality ratio has decreased from higher than expected to unexpected, and we have achieved this. And also our summary hospital mortality indicator, we've also achieved this. The one thing during the year, smoking and alcohol, we're still working with our ICS colleagues on a long-term plan for the tobacco dependency work across the system. And the goal is for this to be a treatment pathway that offers timely, effective specialist support to ensure patients remain smoke-free whilst under the care of the NHS. As you can see, we've got a way to go with this, and it will feature in our next year's priorities. Next slide, please. So the cancer experience, for patient experience, we participated in the 2020 National Cancer Patient Survey, which was voluntary, but we undertook it, and we did see an improved picture from our National Cancer Dashboard. The score of 86% for being treated with respect and dignity while in hospital, and over 90% for those contacted on discharge from hospital, shows a demonstrable improvement to patients, and from the patients saying that they saw a CNS was 45% to 87%. So we've done some absolutely amazing work there. The friends and family test, we have seen satisfaction scores between 87 and 91%, comparing to figures in 2020 where they were 88.5. So again, we've done some work around that and have achieved. Dementia training was affected by COVID but has restarted, so we're not quite there, we're almost there, but we're back on track, and we've got 74% trained at tier 2 and 68% trained at tier 1. And our outpatient services at NGH provide by individual directorates, but we're looking at the centralised model. We're not quite there, but again, we can take that on into next year. Next slide, please. So maternity and neonatal care, as Fiona has alluded to with Ockenden, we now have the new East Kent report and the Saving Babies' Lives. We wanted to look at some of the things within our maternity services and reducing smoking in pregnancy. 100% we have a booking rate of last year, which was a great achievement. Risk assessments within Medway for the birth centile was at 100%, and women at risk of stillbirth, there was 100% of women given aspirin of 150 milligrams. Again, lots of ongoing work. We've achieved it, but we still need to achieve more. There was a great thing that there were 2 RCM awards presented at the maternity services for excellence in maternity care during a global pandemic and excellence in race matters. Next slide, please. So next steps for Northampton, we'll absolutely continue to concentrate on improving the quality priorities of 21-22, especially around pressure ulcers, smoking and alcohol, dementia and outpatients. But as Dr. Hardwick has alluded to earlier in the presentation, we continue with the exceptional deteriorating patient work for zero harm care with our patient safety team. We will progress the implementation of the Patient Safety Initiative Response Framework. We will continue to improve and reduce harms for our tissue viability, falls and infection prevention, especially C. difficile. As Fiona alluded to in her talk, we will extend and develop a culture of psychological safety for staff at all levels through what Heidi has described as the Connect, Explore and Improve. And NGH is on a journey to redesignation for Pathway, which again will also help with the culture work. We also need to be looking at supporting patients to leave hospital, and we will also continue to improve and expand our learning from death. And most importantly, patient experience is the way we communicate with patients, carers, relatives and ourselves. Thank you. I believe I'm handing over to Professor Peter. Thank you.
Good morning, everybody. I'm Peter Williscroft. I'm the lead juror at Kettering. Many years ago, I was told when you're starting a presentation, you should never start with an apology, but I'm afraid I'm going to go against that today by saying, I'm sorry, I've got a terrible cold and a croaky voice. So I apologize in advance for that, but let's see how we go. First slide, please, Richard. Well, you've heard from some of the speakers this morning what an exciting time the hospital's going through. And it's clearly just as exciting for us as governors. And I'll explain a little bit more about that as we go ahead. Today, I'm going to talk about the two items highlighted in bold. There's an awful lot I can talk about, and I've produced some slides with some of the details on them. And if anybody wishes to look at them and come back and talk about them later, then please do so. First slide, please, Richard. Just a little bit about the Council of Governors. As you can see, we now have 28 governors made up from the public elected governors, which you, the members, select, nominate governors to come forward, and in unchallenged cases, they will be automatically elected as a governor. Otherwise, there'll be a voting arrangement and you have an opportunity to select the governor that you wish. We have 8 staff governors representing the 4,000 staff on the site, and we also have 5 governors dealing with the areas that we've identified there, which are excuse me, Health Watch, Mind, Age Concern, and the local authority. This year we've expanded it to take account of the local authorities, and because there's been a change in the system, as you all know. Sorry, next slide, please, Richard. The governor's role covers a great deal of activity, and I've highlighted the bold areas which I want to talk about today, but there are several others there, as you can see. It's an exciting role that we have. And I think it's important at this stage to be very clear about the fact that governors are not paid for by the trust. We are volunteers. We are independent of the trust in many ways, although we do comply with much of the governance of the trust, and clearly the confidentiality area of it is paramount. But as non-executive, we are not paid by the trust. So let's move on. Next slide, please, Richard. It's important that we set out what we are not involved in. And I think many of our constituents think we cover some of these items, but let's just go through them. We're not there to take on individual concerns. We are here to signpost you to where it can be dealt with by the trust in the appropriate department. We don't make operational decisions. Some people think we're similar to school governors and people of that sort, and we're not. We don't direct any staff at all. We have no executive roles. we're not here to represent our own interests, personal or otherwise. And of course, we are not here to get favourable treatment of care. We do, of course, represent our constituents and take forward individual cases to, as I've said at the beginning, to places where they need to be dealt with. Next slide, please, Richard. So here are some of the duties of the governors, and you can see it's quite a wide range of activity that we carry out on a regular basis. But the important things, I think, which is why I've highlighted them, is our relationship with the community and our members. We are trying very hard to open up avenues of communication so that we can get a proper two-way conversation. We are keen to understand how our members and our constituents want to interface with the hospital. Sometimes it's not easy to speak with authority, but through the governors you have an opportunity. And of course, we want to hear how you value the contribution of the hospital and how you want to fit in with that. Can we have the next slide, Richard, please? Non-executive directors. I just want to say a little bit about non-executive directors, because in a similar way, as I said earlier, they are not on the trust payroll. They are, as a foundation trust, they are there to add public accountability to the operation of the hospital. Foundation trusts are theoretically self-governing trusts, which means there needs to be some form of accountability. And this is why the non-executives are employed to give that accountability in a particular way. The governors, however, are there to ensure that the public accountability is managed properly and is accounted for, and we hold the non-executives to account. They in turn manage the trust board, and they are accountable for the performance of the trust. So we have excuse me, the trust board is managed through board committees. We have 3 principal committees as it sets out there. We have committees in common with Northampton. Now, the important thing to recognise here is that on each of those board committees, we have a nominated governor who will be observing the non-executive who chairs that board committee. Each board committee has at least another non-executive on, so it gives an opportunity for the governors to observe how the workings of those committees are carried out, and it allows the nominated governors to inform the rest of the Council of Governors on the performance of that particular committee and the non-executives who are managing it. As I've said at the bottom there, at the moment, these are all virtual for obvious reasons, but we're moving slowly towards a face-to-face set of committee meetings, which I think will be advantageous for a number of reasons. I think most of us will recognise that if we can speak to one another around a table, there's lots of different nuances that come out of that. And of course, we're looking forward to that. Next slide, please, Richard. A little bit about what we've done. Last year, I presented at this meeting the fact that we were awarded by the NHS Providers National Virtual Council Committee an opportunity to present our showcase. This showcase focused on how we were trying to communicate with our members through writing articles for the Evening Telegraph newspaper, and it was thought by the provider organisation to be a good example of how we were interfacing with the community. One of those articles was around the ICS, which was still at that time quite in its embryonic stages. So as a result of wanting to look more into that, we got together with our neighbouring trust Northampton Healthcare Foundation Trust to look at whether or not we could work together to explore this further. I think perhaps the best thing to do, Richard, is to run the video because it'll explain it far more than I can in my croaky voice.
Coming right up, 1 second.
Healthcare NHS Foundation Trusts met to explore areas of joint interest in light of the proposed development of integrated care system arrangements, as they were keen to understand the governance structure of the ICS and governors as stakeholders in system working. In response, both trusts and Northamptonshire Health and Care Partnership organised 2 virtual briefing sessions for the governors. This enabled the governors to appraise themselves of current developments, progress, understanding of the legal framework around the ICS, and their role as a stakeholder in system working. The well-attended sessions involved breakout groups for governors and non-executive directors. This allowed a knowledge exchange on areas of joint concern and interest. These sessions were well received, with overwhelmingly positive feedback from those involved. Whilst retaining their statutory obligations to their individual organisations, the governors felt they would be able to help support the ICS with developing a framework for working with local communities. There will be a follow-up session in 2022, which will deep dive into how ICS joint working is making a tangible difference to communities. Working together across the 2 trusts has enabled governors to identify mutually beneficial areas for collaborative working.
Thank you, Richard. I think I've got another slide, actually.
Richard's clearly working his way through the slides, Peter. We'll get there in a minute, I'm sure.
Okay, well, that will give me a little...
Yeah, Richard, you've got 2 slides to bring up, please, right at the end.
A little bit of a respite to my voice, thank you. While Richard's working his way through that, I just wanted to say that the NHS Providers is it's a membership organisation where every trust in the country has an opportunity to join it, and I think do, but it's there to help foundation trusts ensure that we get efficient and highly efficient workings. So they are quite a prestigious organisation, and to be selected 2 years on the run to give a showcase presentation to the rest of the country, I think is something to be celebrated, and I'm very pleased that we were able to do that. So thank you, Richard. My next slide is this is about the other activities that we carry out as governors. We have a communication group, and as I've said at the beginning, despite my voice, we are keen to get communication between ourselves and the membership, and this group actively sits around to try and develop different ways of doing that, and we bring other people to the meetings so that they can help us through this. And we have a great relationship with members of the trust, particularly in the areas of patient-facing departments, and so we're really keen that we continue with that throughout the year. Something we've introduced just recently, and I suppose in theory this wasn't part of last year, but it is currently going ahead, is our green group. And as you can see, the trust is committed to achieving the targets set out by government. And although we aren't involved in the day-to-day operation of the trust, what we are intending to do through our green group is to look very carefully as to how we can add further benefit in a more practical way to both members of the public, our members of the trust, and also staff. And simple little things might be signposting them to areas where they may be able to get items of household goods which they are perhaps struggling to get hold of, and things of that sort. So it's It's not a high level energy saving area, but it's something which we think will just add an extra layer of help to members of the public and staff. Next slide, please, Richard. We are elected by and large by you, the members, to serve on the Council of Governors. But it's important that not just elect us, but you actually engage with us to let us know exactly what you want to hear from the Trust, how you want to hear from the Trust, items of interest. So please make sure that you contact your local governor. It doesn't have to be your local governor, it could be any governor, but please make sure that you do and set up a dialogue so they can get a proper two-way conversation going. A full list of governors are sitting on the website, and the office in the governor office will help you through the individual contact details. Thank you for listening to me, and I'm sorry it's been a bit croaky and a bit disjointed, but I'll hand back to Alan now.
Thank you very much, Peter. Back to me now as chair of both hospitals to just finish off this with some question and answer session. The first thing I want to say is thank you very much, Peter, for manfully stepping up to the plate. I'm sure your deputy Mabel was delighted, given she had audio difficulties, that you didn't back out and just leave her to do this little task. The other thing I think it might be worth making clear, because this is a joint annual members in the annual general meeting for the two hospitals, is that only Kettering is a foundation trust, so the governor's story only applies to Kettering General Hospital. Northampton General Hospital is an NHS trust and does not have governors. So finally, can I just say there is a question, again, there is a question and answer button available on your screen to anybody watching this. We have a couple of questions, and I'll come to those in a minute, but if there's anything else you want to raise while we're answering those two questions, please use the Q&A function on your screen and we'll see them and do our best to reply to them. So the first question we have is, how does the robotic system work between the trusts? So since it's situated in Northampton General, I'm going to ask Heidi to answer that question, recognising that as we said right at the beginning, part of our strategy is to make Kettering a centre of excellence for cardiology care and Northampton a centre of excellence for cancer care. And this robot is primarily used in cancer surgery, which is why it's there. Heidi, would you like to just pick up how this works and will work across the two, or for patients from both trusts?
Well, I think it's thanks, Alan. So of course, happy to answer this. So as Alan said, the robot is obviously physically located at Northampton, but it is absolutely a robot that is going to be utilised by our teams across both hospitals. So Dr. Made, who spoke about the robot, is a medical director here at Northampton, but he is key in leading that collaborative work across both hospitals. So the benefits are not only the obvious benefits for patients, but for training and obviously surgical advancement in terms of what our surgeons want to do, so attracting people to work at both sites. So it will be utilised by both of our teams. That will happen over the journey of the Cancer Centre of Excellence, because we use it for some sites at the moment, but we'll be expanding that. It will benefit patients across the whole county. So as we develop our Cancer Centre of Excellence, obviously that will continue to expand as our expertise in the area develops. But it is something that Debbie and I, as both Chief Executives, I'll be leading the Cancer Centre of Excellence and Debbie the Cardiac Centre of Excellence, but we and the clinical teams will work very collaboratively to make sure the benefit is across the whole county.
Lovely, thank you very much. The second, Hemant, do you want to add to that? No?
Thank you, Alan. As Heidi has said, the robot is currently been already utilized for patients across both the trusts, and staff across both the trusts are jointly working as teams and getting trained. So it's absolutely been used for both the trusts. And I think the second was around the system being rolled out to the KGH. So I will just take that question as well, if I may, Alan, is that yes, we have an absolute ambition to expand and explore new platforms. And then we will look at expansion, whether it's in the new build at Kettering or somewhere else, that will come with time. Thank you.
Thanks very much, Hemant. I'm going to a second question I've got now. Sorry, it's quite complicated on my screen. There is a question about which actually says, is this system being rolled out to KGH? I think the question refers to the deteriorating patient checklist that was described by our consultant anaesthetist from Northampton. So is it being rolled out to KGH, to Kettering Hospital? Debbie?
Yeah, thank you, Chair. So at the moment at Kettering, we have a programme with 7 work streams on how we better manage the deteriorating patient and the safety around the deteriorating patient, of which digital is part of that. So how do we use new digital and innovative tools to make sure that when patients are deteriorating, that is escalated and digital information is then sent to the relevant people so that they know straight away and can act. And as I say, digital is one of those 7 work streams. So the solution may not be the same solution as Northampton General, but we will certainly have a digital solution in place.
Lovely, thank you very much. I don't think I have any. Oh, I do. I have a question around improving our elective activity. As we've said at the start, I think both Heidi, Debbie, and our group chief exec talked about how well we had done during the pandemic in keeping our waiting lists under control. And our waiting lists remain in the upper quartile, both regionally and nationally. So our waiting times for patients are in a pretty good place. And we have been offering what's called mutual aid to our colleagues to the north in Leicester to try and help them clear some of their backlog. But nevertheless, clearly, as anybody who reads the national papers will know, and we are no exception, recruiting theatre staff is a significant problem. Through recruiting all our staff is a significant problem, with various overseas recruitment initiatives, various training initiatives, all of which take some time to bear fruit. There was a question, Debbie, about what are we doing to, I think it's aimed mostly at Kettering, what are we doing about recruiting theatre staff to try and reduce the number of theatre sessions being cancelled. Can you just pick that one up for me?
Yeah, I will do. Thanks, Chair. So I think I spoke a little bit about this earlier in terms of some professions have been really quite difficult to recruit to. Theatre staff is one of those, and we do need to improve on that over the next 12 months. It is an issue across both hospitals and specifically within operating department practitioner roles. Nationally, this is a hard to recruit to area. So both hospitals are and will continue to do specific recruitment events, utilise different ways of working so that we are backfilling roles with different members of staff who've clearly got the right skills to do that. But we are concerned and we are fully aware that there are quite a lot of gaps for theatre. But what that hasn't meant is that we've had to cancel huge amounts of theatre lists. That has not been the case. We have had to cancel some, and my sincere apologies to those patients who that has happened to across the county, but we are absolutely doing the best that we can to fill those vacancies. Heidi and I work really closely on this. You may want to contribute.
Heidi, anything you want to say?
I think it's still on you, Alan. Oh, so as Debbie said, we've got both hospitals got similar challenges, particularly in ODP, operating department practitioners. We're working as much as we can to learn. Both our chief operating officers are working really closely. And as Debbie said, whilst we are cancelling some, we are doing our absolute utmost and being recognised for that across both hospitals to continue as much cancer and elective activity as we can. So it's something where we're having a proactive recruitment drive, thinking about other roles, thinking about staff retention, and doing some really positive work actually led by the clinical team. So again, we're working as collaboratively across the group on this because it's a national challenge.
Okay, thank you very much. I don't have any more questions on my screen. I'm looking at Richard Apps, who's shaking his head and saying we don't have any other questions either. So I'm going to bring this meeting to a close just by saying thank you very much to all the presenters. And thank you very much to all of those who logged on to listen to the reports and the presentation, which is an important part of our accountability to the public. I'd like to finish as I started, really. Let's hope that when we do this next year, we don't have to talk about COVID and we don't have to talk about a winter flu pandemic, which brings the hospitals to their knees. And let's hope that we can talk more optimistically about reducing the number of patients in our hospitals who shouldn't be there, who should be back at home in the community or in nursing homes. And just repeat, if you haven't, get your COVID and your flu jab. And if you have a young child not yet at school, make sure they get a flu jab, because that's a particularly worrying area this year of infants with respiratory disease. So thank you very much to everybody who attended. Thank you very much to the presenters once again. And I'm finishing now. Thank you very much. Goodbye.